Father, let your Spirit be our guide. And Lord, we ask that you open our eyes to wisdom and knowledge, that it will help us to be efficient in the marketplace as we take steps to establish your kingdom in the marketplace. Thank you as you help us today by your Spirit, and each and every one of us will be blessed. In Jesus' mighty name we have prayed. Amen. Once again, you are welcome. For the benefit of those of us who may not have known much about the Kingdom Summit is an annual non-denominational international marketplace economics and leadership conference. And we will always be grateful to these gentlemen. Ben, we thank God for their lives and what he has used them to do in the area of the Kingdom Summit. Thank you, Pastor Ben and Pastor Brett. Also, we need to understand that the Kingdom Summit was set up in pursuit of 5 key objectives. First is leadership, to raise godly leaders who will influence the marketplace and society for God. 2 is convergence, in a consistently standing for God at work, family, and church, which is let your life be consistent. You don't have to be, some people are different people at work and different people at home, but this is where your life across the different spheres reflect who God wants you to. The other bit is kingdom impact, establishing and conducting business using godly principles, in evangelism, propagating the gospel in the marketplace, and bringing the good news to the business community. And of course, integrity, saying what you mean and meaning what you say, and being ethical in purpose and practice, being consistent in words, and action. For today, we are going to kick off with healthcare. We're going to have 4 sections today. First will be healthcare. There will be 10 minutes break in between, and then we go on to have media and technology, another 10 minutes break in between, and then we have the agri. Close out at about 3 o'clock with education. So when you all clear my schedule and just sit tight, because God has a lot in store for us today. We have all the panelists lined up to share a deep knowledge with us across the sectors that will help us to be real apostles in the marketplace and help in establishing God's kingdom even in the marketplace. For us to kick off this morning with the healthcare, it's my pleasure to introduce the moderator of the healthcare section. His name is Dr. Donald Emoseme. Dr. Donald Emoseme is an accomplished healthcare professional with decades of experience. He's a consultant obstetrician and gynecologist. Let's welcome Dr. Donald Emoseme. Dr. Donald, over to you.
Hello, Brad Chioke. Thanks for that wonderful introduction. On behalf of Hello? Okay. Hello, Brad Chioke.
Can you hear me? Yes, you can go ahead.
Okay. So thank you very much for that. Thank you very much for that intro. May I use this opportunity on behalf of the organizers of this summit to say a happy welcome to all the participants to this session that is the healthcare session. And it's understandable why this healthcare session is very important, given what we are going through in this year, 2020. I hope that at the end of the session, the participants are going to be much better informed. It's going to be very educative and very informative. The format for this session is very simple. We have two accomplished speakers who each will have 20 minutes to give their presentation, okay? At the end of that, it's going to seamlessly move to the next presenter, who is going to do another 20 minutes, okay? We are very, very weary of time because of what we have. During this period, participants are encouraged to note, their questions, comments, and if possible, contributions. All these could be sent in via the chat boxes, via the chat box, so that at the appropriate time, when at the end of the day we are going to have another 35 minutes, for Q&A. Some of those, questions chatted in will be brought in, and then more importantly, we'll have an opportunity to even have, a healthy conversation and discussion. So once again, you are welcome. And without much ado, I want to ask, that we have an intro video, for the first speaker, Dr. Thomas P. Dooley, an accomplished, tighter in his own ecospace. Thank you very much.
Thomas P. Dooley. Dr. Thomas P. Dooley is a research scientist, inventor, and entrepreneur with senior management leadership experience in pharmaceuticals and biotechnology. He has invented multiple biomedical products, most notably Pan-X drugs for anxiety, and is the recipient of 15 issued patents. Dr. Dooley is a highly effective communicator as an international speaker and author of 75 scientific articles, in addition to 4 Judeo-Christian books. He is an international influencer from the prisoner to the president levels. He is also an advocate for manifesting the kingdom of God in the marketplace and all aspects of life.
Hello, this is Tom Dooley. I trust everyone can see my image at this time, and I'm grateful to join you. I'm calling from the USA, and so it's very early in the morning here, but I'm very grateful to be with you. Nigeria holds a dear spot in my heart. I have traveled to Nigeria on 2 occasions and have had wonderful opportunities there in Festac and Acacia and Ibadan Highway, and so I'm somewhat familiar with Nigerian culture, as well as what the kingdom of God is doing mightily through Nigeria. So very, very grateful for this opportunity, and I thank our organizers for this invitation. So I'm going to do a screen shot so that we can see my screen. And I trust that you can see where we're at now. The purpose of my talk today, as well as our second speaker, is on the theme of building a resilient healthcare system for all post-COVID-19. And this is a very, very relevant topic for the day. And I'm bringing the perspective of a PhD scientist who works in the pharmaceutical and biotechnology industry to bear, as well as an individual who works in a broader context amongst the kingdom of God and other manifestations of life. So with this, let me continue the presentation. All right, so in order to build a resilient healthcare system, one must first learn the lessons from the problems that we've experienced during the pandemic of 2020. So I want to summarize for you sort of the landscape of what have been the major challenges that have been presented to healthcare providers and public policy makers during this season. So first of all, the pandemic preparedness by governments and healthcare providers was grossly inadequate. There were many opportunities to address this early on that were insufficiently addressed because of the lack of preparation in advance. And this rapidly overwhelmed healthcare systems in regions and in nations, and before long, the entire world was subsumed by this pandemic. Now, we know that this started in China. It is exceptionally well established through molecular biology that this was a bat-borne, naturally occurring virus that came from somewhere in or around the Wuhan, China area, and that it rapidly overwhelmed the healthcare capacity of that region. And China was slow in handling and containing it through isolation and quarantine and other policies. But China alone was not the only country who suffered. It also affected Europe. We had one example of this where policies were, I think, very poorly handled was in India. I was in India speaking in March when, just prior to the full manifestation of COVID in India, had a difficult time leaving, but shortly thereafter, the leader of the nation, Modi, enacted a very extreme, harsh clampdown policy that I think was very ill-conceived and actually caused, I believe, propagated spread rather than containing it, and it greatly harmed the poor of India. Now, another problem that we've had is that social media, speculations, and conspiracies have been rampant during this time. And as a believer and a follower in Jesus, we must be men and women of integrity, men and women of the truth. And the last thing we need are Christians who are espousing things that are not factual. And in this season, I can tell you, I have observed tremendous amount of misinformation that has been spread by Christians worldwide. And I'm just saying that up front. This is some of our own dirty laundry. We as Christians own this, and we should do better in the future. Now, what are the problems, other problems that have occurred? We've had economic and unemployment consequences because of isolation and quarantine. And one of the things that I think would have been very helpful early on was for governments to establish policies that created immediate stage risking for various regions or various sectors of the economy. They could have easily adopted a policy that said your region or your business sector is subject to a red warning status, the most stringent, or a moderate level yellow, or a you're good to go green level status. Some countries are beginning to do this. You'll notice that the United Kingdom has recently adopted this kind of a three-tiered risk mediation strategy. I wish we had done this earlier in this year. I wish we had done this at the turn of the year in the United States in February and other countries subsequent to that. It would have helped tremendously. Another thing that's worth noting is that scientific evidence is not binary. By that, it is not a yes versus no thing. And we've had a lack of good communication about the validity of scientific experiments and clinical research. There's been a lack of clarity of communicating the value of scientific studies. We've had tremendous amount of information presented as fact when in fact, from a scientific or a clinical researcher's point of view, it has minimal impact. It's minimal bearing. Anecdotes, a single physician who said, well, I tried something and it seemed to work in my hands. Well, it's not scientifically robust compared to randomized clinical controlled trials. So what we need is evidence-based science that leads decisions. And in this context, we also need for the media to understand that there are gradations, there are levels of scientific rigor. And it's not yes versus no, there are shades of gray. And then finally, we've had miscues from the World Health Organization, from the United States Centers for Disease Control, as well as politicians who at times have tried to give their best informed advice at the time, but they've missed the mark. They've either misunderstood the cues at that time or they were frankly not operating in the right realm. So another problem that we've faced has to do with the problem of statistics and its meaning. For the past 7 months, there have been a lot of problems related to this, and I'm sure that our subsequent speaker today will be addressing some of this from an epidemiologic and risk point of view. But the statistics are often misunderstood and misleading. What we're informing the public about is the number of infected individuals, whether they're presumed or confirmed, the number of fatalities, and that can be measured in different ways. Is it a presumptive death by COVID? Is it a confirmed diagnostic test that supports that? Is the primary cause due to COVID, or is it merely they died and they happened to be infected with COVID at the time of death? So that's complicated. It's worth noting that overall, that the relative risk for death is extremely high for those who are elderly, and it's minuscule for those who are very young. And sort of a rule of thumb that one may use is that 75% of deaths from COVID-19 occur in patients that are age 75 or older, whereas the risk potential for a young individual, say a 12-year-old child, is exceptionally low. And there was a lot of confusion about relative risk amongst those two demographics. A next question was, do masks work to prevent the spread of the disease? And this has been bantered back and forth amongst the scientific community. And most recently, the belief has been that they are very effective at preventing an infected carrier from presenting particles to others and placing them at risk. So it's an altruistic action one is taking. By wearing the mask, you're preventing the population from receiving risk from you. There was much less information until very, very recently that suggests that the mask actually bore any benefit to the wearer. And there seems to be some controversy, but some growing information over the last several weeks that suggests even wearing the mask for yourself provides some protection. And then finally, what about physical distancing? This is often called social distancing, which is a misnomer. It's not a correct use of terminology. And the ultimate question is 2 meters sufficient and beneficial? So going forward, additional problems that have occurred is that fear, confusion, and rapid changing science guidance has produced distrust of experts and authority. I have never in my life as a scientist, and I've been an accomplished scientist since the 1980s, I've never seen a period in life where the general population distrusts scientists as much as right now. I can't explain all that, but it's a real problem. Perhaps it's based in fear, perhaps it's based in anger, that people feel isolated and frustrated and they believe that scientists are to blame for this. Now, another problem that we have that is likely to grow tremendously in the days ahead is because of the lack of social interaction and the loss of income, the economic impacts, we're going to see a rise in mental health problems related to anxiety, depression, and suicides. Each of these three is already on the rise. It certainly is true in the Western world, in the US and Europe, and I trust will also propagate as well into West Africa. So why is the healthcare system lagged behind in COVID, in the response? Number one, it was a brand new virus that had escaped from bats to humans. The novelty of the virus, created problems. Second, because it was new, there were no immediately available diagnostic test kits. Although scientists are capable of rapidly developing and commercializing polymerase chain reaction or PCR tests or antibody tests, there was still a lag in development and scale up of those so one could distribute those products widely to those that needed it. Another reason is that prophylactics or preventatives that are used, there were none. There was no obvious prophylactic measure one could take. The next strategy that was important was medications that were already approved by government agencies that could be rapidly repurposed and used again. So for instance, a medicine that had been used before for allergy or pneumonia treatment or a steroid? Could it be repurposed quickly for the treatment of COVID-19? This is an area where I have been working. Finally, in the hospital side, the need for intubation and ventilation and critical care settings was rapidly overwhelmed. And lastly, there were no vaccines because it was a new virus. And we're beginning to see, even with the announcement this week from Pfizer, of promising signs of an effective first generation vaccine. So in order to build this resilient healthcare system, I want to provide 3 examples from my own life over the past year where I have been involved as an individual intently interested in advancing the kingdom of God in the marketplace, and in particular in the healthcare pharmaceutical sector. And I want to use these 3 examples as testimonials of how God has already positioned men and women who are influential in the kingdom of God, who are already embedded in the COVID-19 crisis. And I want to provide quickly 3 examples for you. Now, the first and probably the most relevant to this talk is that when I returned from India, I was invited to be a participant and a scientist helping to co-invent a repurposing of 2 known medicines that are over-the-counter in the US and over-the-counter in most nations in the world for the treatment and the rapid distribution for treatment of COVID. And so the problem we faced was there were no over-the-counter medications that were known to treat COVID back in March. However, we have since discovered the combination of 2 medicines that are very common worldwide. The first is cetirizine. It goes by the brand Zyrtec in the US. And the second drug is famotidine, or the brand name Pepcid. These 2 medicines both block histamine. Cetirizine blocks histamine 1 pathways, and famotidine blocks the H2 pathways for histamine. And as a result of the marriage of these 2 agents, they can then converge and block the so-called cytokine storm that causes a lot of the pathology in lungs during the ARDS symptoms that develop. So we conducted a trial in hospitalized patients that were severe and critical. We had 110 patients treated in this manner, and we reduced the rate of death by 1/3, and we reduced the rate of intubation or the ventilator dependence by 1/3. This is a tremendous improvement on extremely sick individuals. Most of the subjects in this study were African American. Most of them had comorbidities such as obesity, hypertension, cardiovascular risk. These were very, very sick subjects, and yet we were able to reduce their burden for death and also ventilator dependence. And a study was published in a very good journal, Pulmonary Pharmacology and Therapeutics. First author's name is Hogan, and this work was recently published. These compounds are available worldwide and are already being used internationally for the treatment. And the very thing that's very nice about this is this can be used by individuals outside of a hospital setting as well. Now, the second example I want to tell you about quickly is I mentioned the rise in mental health concerns, and especially the rise in anxiety at this time. Another class of medications I've been working on are to replace benzodiazepines, drugs like Xanax or Valium or Ativax or Klonopin. Now, benzodiazepines are very effective medicines for the treatment of anxiety, but they have very serious side effects. The chemical dependence, tolerance, addiction, and abuse. And these drugs have been in wide use since the 1980s, but federal governments, and in particular led by the US FDA, are now issuing warnings against the use of benzodiazepines. Now, the reason that I developed this was because of my own son. My youngest son, Thomas, when he was an adolescent, he was about age 12, age 13, he developed acute anxiety, an obsessive compulsive disorder. As a result of it, a psychiatrist prescribed benzodiazepine drugs for him, and my son had a very, very difficult time on those medications when he was a high school aged youth. He later developed an addiction, and his addiction developed towards opioid medications because opioids would relieve his anxiety symptoms. As a result of the struggles that my son faced, and unfortunately, I lost my son Thomas to a drug overdose 3 years ago. So for more than a dozen years of his life and a dozen years of my life as his father, I was trying to come up with a way to solve this problem. This was a God-breathed invention. And God breathed into me and inspired that I could repurpose 2 old classes of medication. One known as beta blockers that are used for the treatment of blood pressure, and another class of agents that are called antimuscarinics that treat motion sickness. And if I married the 2 together, they would work together to replace benzodiazepines as fast-acting treatments for anxiety, yet without having the potential for addiction or drug abuse. We now have 4 patents issued on this in North America. We're soon hoping to get patents issued on these compounds as well in Europe. And I believe that this Panex invention that was God-breathed is likely to be very, very beneficial for people who have occasional need for relief of anxiety symptoms. Now, the third example I want to tell you that I've been actively involved in this year is since the month of April, I've joined with a team of a company called Liveful. The founder is a gentleman named Hogan Bassi. He is Nigerian. And Hogan was the founder of the company. And what the company is focused upon is building a global healthcare access company, and to do so in a way that's very unusual. Most healthcare companies are developed around technologies that are very expensive to develop, and those expensive development pathways are usually fostered in the US or Europe, perhaps in Japan, but they're developed around the top of the economic pyramid, those individuals who are affluent. And our concept is to invert that and to make highly affordable but scientifically valid healthcare products that can reach even the least of these and make that the primary objective of our development of our technologies and our sourcing broadly. So Liveful is engaged in identifying and distributing globally scientifically valid and affordable healthcare solutions. We currently are selling COVID-19 PPE and diagnostics, where we have partnerships with large NGOs such as Mercy Ships and World Vision, and we're deploying through a network of NGOs throughout the world. We also have a novel consumer product that is an insect repellent called Akiva, and Akiva is a long-lasting, sustained-release formulation for mosquitoes that has great promise for use, in particular in West Africa and the tropics, as a preventative for malaria. So stay tuned. We have these products being launched now in West Africa and have a study ongoing right now in Ghana, as well as other countries in Africa. So this is an exciting new product launch, and it has products superior to any other insect repellent out there today. And then finally, we're also going to be working on therapeutics, and one area in therapeutics will be on wounds, cutaneous wounds, skin wounds, and we'll be launching products as well there into third world markets and mid-pyramid markets. So those are 3 examples from my life of this year, and I highlight those because even the Apostle Paul used the example in Romans 15. He said that he used testimonies of the power of God working through him for the salvation of other people. We need to be bold in acknowledging the ways in which God has enabled and equipped us with information and resources and capabilities and knowledge, and develop these testimonies that are altars of remembrance from our own lives that we can share in the marketplace. I'm very bold at sharing in the marketplace my faith. I do it constantly with government leaders, business leaders, university leaders. I do it unashamedly. One of the ways I also do that, besides speaking professionally with them and speaking, say, on bioethics or issues of ethics and morality, is I share with them books that I've authored. If you're interested in any of my books, I write on virtues, faith, hope, love, truth. My books are available for free as ebooks at one of the websites listed here. You could certainly look at my website, tomdooley.org, and find appropriate links. These books are available for free to anyone who would like. And I want to thank you for your time. Now back to our host.
Thank you very much for that very brilliant presentation, particularly from the perspective of a scientist. Also, the bit about what happened to your child resonates with us, and we're very thankful to God that you've taken it in great strides and you moved on very strongly. Thank you very much. We are going to our next speaker, and we want to call for, a show of the profile of Dr. Chikwe Ihekwazu, the DG of NCDC. Thank you very much.
Dr. Chikwe Ihekwazu. Dr. Chikwe Ihekwazu is the Director General of Nigeria Center for Disease Control, NCDC, and was until January 2018 the Acting Director of the West Africa Regional Center for Disease Control. He trained as an infectious disease epidemiologist and has over 20 years' experience working in senior public health and leadership positions in several national public health institutes, including the South African National Institute for Communicable Diseases, NICD, the UK's Health Protection Agency, and Germany's Robert Koch Institute, RKI. He has led several short-term engagements for the WHO, mainly in response to major infectious disease outbreaks around the world. Dr. Ihekwazu is a graduate of the College of Medicine, University of Nigeria, and has a Master's in Public Health degree from the Heinrich Heine University, Dusseldorf, Germany. In 2003, he was awarded a fellowship for the European Program for Intervention Epidemiology Training and subsequently completed his public health specialization in the UK. He is widely published in medical peer-reviewed journals.
So thank you. Good morning, and thank you for your kind invitation to share a few thoughts with you today on the response to this life-defining pandemic that the whole world is going through, and of which we're particularly affected in Nigeria. Thank you for the organizers, and thank you for my colleague. Excellent talk before this. Learned a lot from it. So I thought I'll use this opportunity to really reflect a little bit on some key aspects of the response in Nigeria, and then also reflect a little bit on the future and the topic about building resilience and finding the courage to do so in our context of competing demands on resources. So I'll try and share my screen. And then enlarge it. Thank you. So I hope you're seeing it now. If not, please shout. I will spend the next few minutes, the little, very short overview that is important for the rest of the presentation in terms of health in Nigeria and some factors that affect it that are important to put the rest of the presentation in context. Say a little bit about NCDC and the outbreak, Nigeria's response so far, and how I think we can build resilience moving forward. So firstly, many of you would be aware of this, but I put this here so to really have it at the back of your minds as you reflect on the rest of the presentation. Firstly, that we have a federal structure, a federal government. And that has big implications on the ability or inability of a federal government parastatal to respond to an outbreak. So very often during the outbreak, you see a voice note spreading on WhatsApp on why NCDC is not picking up a patient somewhere in the country. I think there was one in Kano that went viral. Well, that's not NCDC's responsibility. Our responsibility is to support the states. It's the state's primary responsibility to provide that service to individual patients. So there was a lot of uncertainty and ambiguity around what is the role of NCDC vis-a-vis what was the role of the state government and the state government's infrastructure in responding to an outbreak. It is only the security forces in Nigeria that have a command and control responsibility and mandate in Nigeria. And even that is being questioned in terms of policing. So we have to be very much aware of the pros and cons of having a single command and control opportunity when there's a national crisis, vis-a-vis the very complex setup that we have in Nigeria. Secondly is the population of Nigeria. Now, this literally is the elephant in the room. And if there's something I'd like all of you to continue to reflect on after this, is that our population is growing at 3% per annum. This is a time bomb. It is a time bomb for the work I do for a very simple reason. The more people live in a defined space, inevitably increases the risk of transmission from one person to the other within that defined space as the number of people in that defined space increases. This can be understood even if you don't have any understanding of basic maths. Now, imagine that we're growing at 3% per annum, and the closer and more you are within a defined space, the easier it is for a virus to jump from one to the other. So that as long as we continue growing at this rate, our risk of infectious diseases will continue. And also our capacity to manage it will continue to decrease unless we're building up our health care infrastructure as quickly as our population is growing, which we are not. So this is the biggest time bomb for every sector in Nigeria, whether it's health, education, security, electricity, infrastructure, whatever you can think of. If we don't have a progressive population policy in Nigeria, we will hit a wall very soon. Thirdly, we are investing too little in health. And yes, health is rarely on the agenda because we have a multiplicity of challenges in Nigeria. If you ask the average Nigerian what they want, nobody will mention health. They'll go to light, electricity, water, security. Before anyone mentions health, it's maybe 10 steps down the ramp, if at all. But still, I can't remember anything in our lifetime that has brought the entire economy of our country to a standstill. So if we don't invest in health now, we will pay a price. Yes, this is a pandemic, it's a once-in-a-lifetime thing, but there's no reason to think that it will continue to be a once-in-a-lifetime thing. So we have to kind of invest more in preparedness. We have a bigger challenge in all our health indices. Life expectancy is really a score that brings together both health and all the preconditions for people to live along into one average figure. Our preparedness score is something we do annually, every 5 years. It's a peer review mechanism to assess how prepared we are to respond to outbreaks. Our last score on that was 46, the peer review mechanism where external reviewers come in to review our own capacities with us. And obviously, the last point there, we've had a series of infectious disease outbreaks, which I'll go into in a bit more detail in the next slide. And so I'm now on slide 4, and you see that we have had a history of significant public health events. This is just a summary of the big ones prior to COVID. In 2014, everybody will remember the Ebola outbreak, which we did fairly well in managing in Nigeria. There are lots of circumstances around why we did well. I won't go into that, but we did. It was one of our proudest moments in public health. We saw the re-emergence of polio, which is finally eliminated this year, but cost us 3 years when we found those 4 cases in Borno in July 2016. We had the big meningitis outbreak in 2017, monkeypox in 17, Lassa, consecutive large Lassa fever outbreaks since then. Now, why do I say this? This kind of sets the scene. Firstly, we've had these terrible outbreaks cost us many lives, but it has also prepared a workforce in public health to be able to understand what outbreak control means and were then mobilized to respond to this big pandemic when it came. A bit about the Nigerian Center for Disease Control is Nigeria's National Public Health Institute. It's one of the youngest parastatals, not only in the health sector, in the entire country. It was one of only 2 parastatals that were signed into law during the last administration, the first administration of President Muhammadu Buhari, together with the FCPCC. So a very young parastatal. We are on 3 campuses. We are just building up our workforce slowly. We're just at 300 now. So everyone hears about NCDC. It's a very young parastatal, but thankfully our leaders had the foresight to establish this. I'm the first leader of the NCDC, the first Director General. So you can imagine how much effort we have to make in building up this young organization. Our mandate is to prevent, detect, and control the spread of infectious diseases, to coordinate surveillance systems, to do that, to support the states in responding to small outbreaks and lead the response to larger outbreaks like we're doing now, to develop and maintain a network of public health laboratories, and to conduct, collate, synthesize, and disseminate public health research to inform policy. And also, the last point there is to coordinate our compliance with international health regulations. This is a health law, a global health law that requires every country to report to the WHO when there's a significant public health event in our country. So a bit of a summary of where we are. And I won't go into too much of this because everyone follows this in so much detail every day in Nigeria. Prior to the results from yesterday, I haven't been added to these slides. We had just under 65,000 cases with just over 1,100 deaths that would not have happened prior to this year without COVID. This is the distribution. The map shows the distribution of cases in Nigeria. A little bit about the response structure. We have a presidential task force led by the secretary to the government of the Federation. This really shows the level of importance and prioritization given to this in our country. We sit within the Federal Ministry of Health as a parastatal and lead on the public health response. So all the pillars of the public health response, whether it's surveillance, point of entry, that's all the ports, airports, and things like that, laboratory case management advice. Actual case management happens in states, but we provide clinical guidelines for states to implement risk communications, logistics, research, and infection prevention and control. So this is the basic structure. Of course, it's much more complex than this, but this is the basic structure that we organize ourselves with. Through the Presidential Task Force, I won't go into all the detail, but just to say that even at the very beginning, when we advised Mr. President to restrict movement and other restrictions across the economy, we were very clear at the beginning that given the nature of the Nigerian economy and life, we were not able to sustain a lockdown. So the lockdown was basically to enable the public health response to be started, to be activated, and for us to organize ourselves. But definitely we knew from the beginning that we couldn't have a sustained lockdown. So from the very beginning, we had a phased easing of this strategy already in the very beginning. It might have moved 1 week forwards or backwards, but we always had a phased plan for reopening from the very beginning. And so from the beginning, where almost everything was stopped, to a gradual reopening of offices, the airspace, schools that is happening now, and NYC camps, we're in the middle of opening them this week. We continue to reopen the economy, and we try to do that relatively safely. And so far, we have managed to do that without a resurgence of cases in Nigeria like you would have seen. So a few thoughts about our response so far in Nigeria. Firstly, to say a lot of the work we have done, every night, you will see every single night since February, we have reported to Nigerians on the number of new cases, number of deaths, number of discharges. There's hardly any other public or private institution in Nigeria that gives you daily data on the work that they're doing. This is only possible because we built up an a web-based surveillance system through which we collect this data from all the states, all the labs, relevant labs in the country, analyze, make decisions, and we have real-time epicurves, real-time maps at our Emergency Operations Center through data visualization tools through which we manage the response, manage the strategy, detect spikes in infections, respond to them, understand where supplies are needed, respond to them. All this is possible because of a surveillance tool we call SORMAS. And we have various other tools to manage our supply chain, our laboratory information management systems, etc. So we use this to manage the day-to-day response in the EOC for surveillance. For our labs, this is really where we are at the moment. We started from 3 labs in March, and we're now at 69 labs across the country that are able to make this diagnosis. So we have solved for proximity, bringing labs closer to people in every state in Nigeria. We've solved for scale. So in Lagos, Abuja, Port Harcourt, in the major cities in the country, there are labs that can do high throughput testing. We've included the private sector, a very important component in Nigeria, and sustained the supply chain that has kept all these labs working. So, unlike any other time, you would not have read anywhere in the newspapers that there has been a stock out of laboratory supplies in one lab or the other. And you can imagine what it takes to do something like this in our complex country, to sustain that supply chain of reagents, commodities, because it's not just about setting up a lab. They require all sorts of reagents constantly supplied. You have to understand their stock levels daily and resupply them as needed. And this has taken a lot of work by the very dedicated team at NCDC that has stayed awake day and night to ensure that we can sustain this response for our country. The third point I wanted to touch on is using an emergency operations structure in the response. This is something we really learned from the military. In public health, we are normally we have a very consultative approach. We hold meetings and then we decide to hold another meeting and another meeting. But, since the Ebola response, we've learned, we've taken one aspect of the military response and learned how to use EOCs. EOCs are basically organizational approaches where you learn to make decisions with limited information. With the information you have at hand, you make those decisions, you divide yourselves in pillars, you delegate authority, and that way we can delegate authority to make decisions at lower levels and be comfortable with it at the higher level. And that's what we've done. We have a national EOC, and we've supported every state in the country to set up a state level EOC. We communicate decisions, implement, and assess afterwards. We've deployed, the other thing I wanted to say is, normally you have an outbreak in 1 or 2 states in Nigeria. You move all your resources to support that state. This time we had literally clusters of cases in every state, bar a few that came a bit later. And so we had to deploy teams to almost every state in Nigeria. So we were extremely stretched in having to deploy teams and still maintain a national response. This required an exceptional amount of logistics commitment. We brought in people that had retired, people that had trained with us in the past, but were not necessarily working with us to come in and support this response to sustain it through especially the peak months of March, April, May, June into July. And the other critical aspect of the response is contributing to global knowledge. There have been more than 20,000 publications on COVID so far in peer-reviewed journals over the past 10 months of this disease. Very few have come out of Africa. So we have committed from the very beginning to contribute to the global knowledge and understanding of this disease. This is the first paper we published in an important journal called Epidemiology and Infection, describing the spread of the disease in Nigeria within the first few months from January to June. We have about 10 other papers in process. 2 have been published so far. So we're very aggressive in contributing to the global understanding of the virus. The first full genetic sequencing of any of the virus in Africa, done in Nigeria, collaborating with the Africa Center for Genomics Excellence in Genomics in Ede in Ogun State with NCC. So we keep contributing to the science as well as leading on the operational response. And finally, the last area I wanted to touch on was on risk communication. The previous speaker had already mentioned how important it was to stand and give credible information to the public. This has been a very difficult process because we've had to brief the press through the Presidential Task Force. We set up a website. It's probably the most accessed website in the country. We get millions of hits. It crashed at some point. We increased its capacity. And now we're very proud that that website continues to be a source of credible information. We have over 1 million followers on social media, on Twitter alone. That comes with responsibility. So every single tweet that goes out is vetted to be sure that we are providing credible information for members of the public. But most importantly, I have been pushed very hard to relax on the science, to accept that some magical cure from Madagascar might provide the solution, to consider if we shouldn't do bulk procurement of chloroquine. So you're pushed in many directions to make decisions that are not based on science. And whether I am emotionally attracted to these opportunities or not is really irrelevant, because in my responsibility as the leader of the Nigeria Center for Disease Control, I have to base my advice to our leadership on the best science available. And until we have a clear understanding of what works and what doesn't, I cannot in good conscience make a recommendation around cures that I don't have confidence in based on the best science. So this has been very important, not only to know what to do, but to be able to communicate it clearly and unambiguously, both to the public and to the leadership, political leadership, so that they have the best information possible to make the right decisions. So to the final part of this talk is really to share a few reflections on the outbreak, the response, and what we need to go into the future. The first one is a response to this scale is simply not possible without the aggressive use of information technology. Most aspects of our government are still in the dark ages. Over the past 10 years, we have improved in a lot of things, in our salary payments, for instance, the financial platforms, many of them led by the budget office. So many systems have improved, but many are still really behind the opportunities of existing technology. And we could not have managed an outbreak as big as this. Imagine all the data collection in terms of cases, contacts, hospitalizations, symptoms. Imagine managing the deployment of logistics, supply chain, warehousing to all the states in the country. Imagine managing all the laboratory information systems. None of this would be possible. So we are aggressively transforming NCDC to basically an IT-based operation. We have certain limitations because the laws of the country do not allow us to fully migrate to a completely electronic data system. So we still have to do some approvals on paper, but we're trying to even migrate that to run parallel systems. So at any point you come, we can pull out the documentation related to any transaction, any outbreak that happened in the past, or any of our historical interventions. This is a difficult process because you not only have to build the system, you also have to train the people to use the systems. When I came into NCDC in 2016, the national coordinator at the time was still using a Gmail address to write emails. From the first day I came, we said, my first email out of NCDC must be with an NCDC email address. And things are simple as that, but it's commonplace in government, and we have to really push that we transform our government systems, ministries, and parastatals to use information technology to drive their mandate. This is really what we've done at NCDC. Secondly, we cannot deliver if we don't work with the states. There are two ways we thought of working with the states in this outbreak. Firstly, to implement emergency legislation. Our laws relating to public health emergencies are old, not really fit for purpose, so there's an ongoing process now to change the legislation to enable a more flexible response. However, what we've learned is that yes, laws are important, but there's also a lot of opportunity to build consensus. So between the PTF, there's a subcommittee of the PTF and a subcommittee of the NEC, the Nigeria Economic Council, made up of all the governors of Nigeria, that we meet in 2 weekly intervals to align policies between federal and state levels, and so to ensure that there's alignment in our thinking, alignment in our action, so that when schools are opening, for instance, which is primarily a state government responsibility, we can ensure that similar processes are being implemented simultaneously across the country. This has really worked in most cases. In Nigeria, almost every state governor is aligned, bar maybe one, which I wouldn't mention here. But really, we have tried to align our policies, our work, but we really need more investments in public health at the state level across the country. Sorry, excuse me. Just 1 second. Just 1 second, I have something on my screen. I'm trying to get to the next slide, and I have a disruption on my screen. Incredibly annoying. Can the moderator stop the share for 1 second? Can you do it from there? Thank you.
Dr. Chike Hekwazu, our indefatigable DG.
Yeah, sorry, let me just complete. I think I can get it back up.
I'm sure you would use the opportunity that presents through the Q&A session, to perhaps address, if you don't mind, because of time constraints. I think the first thing is to really appreciate your insightful presentation. We didn't expect anything less, given the great work you've done, and we want to really appreciate and acknowledge your great effort and strides.
Yeah, so sorry about that. I couldn't finish, but I can wait till the end.
Okay, so like I said, so we appreciate you, your very insightful presentation. I'm sure you have some opportunity to complete, the missing bit. A number of questions, have popped up and some contributions. Let me say charity begins at home. And so my first take is to get your perspective on how, either by design or by nature, we've managed to keep, our figures low. If you look at across the transatlantic, by yesterday, America had, a record high number of, daily intake of about 148,000 new cases. I do not think that our incapacity, to muster accurate or adequate data for now will explain why apparently the number of deaths in Nigeria is low. Please, could we quickly have your thoughts on, why the fatality or the mortality rate, looks, on the low side? That is number one. Your thoughts, please.
So thank you very much. The two things I'll say. Firstly is, if that we obviously watch a lot of TV from coming out of the US, and we're all attracted to the data out of the US. But realize that the world is actually very big. If you look at India, cases are declining significantly. You look at Australia. If you look east, you don't see the increase we're seeing in the West. So we mustn't have a view that is completely biased by the stations, the source of the TV stations that we tend to watch. That is the first thing. Secondly, there are many factors that drive infection. The weather conditions that not affect the virus itself, but affect human behavior that therefore then drives infection. So we don't have the weather conditions that drive us indoors, which is one of the factors that lead to an increase in respiratory infections generally during the winter months in the West. That is not a circumstance that we have here, and therefore that is one of the reasons. But my final comment is, imagine that the tables were turned and that we had an increase in infections in Nigeria and none in the rest of the world. Everybody would be criticizing us to high heavens about our incompetence, our failure to act. And now that we seem fairly successful at managing this outbreak, we're all looking for alternative explanations for the work that we have done. What of one of the explanations being that actually we have done fairly well, that we did take substantial action in the beginning, that we did lock down our economy at a great cost to the country. And maybe, just maybe, despite our skepticism around government, maybe we did a few things right to enable us be in the position that we are at the moment. When we instituted the airport controls of 2 tests, one if you're coming into the country, one abroad, and a second one in Nigeria, everyone criticized us for being extreme, for being too strict, but maybe, just maybe, those measures have prevented a massive reintroduction of cases into Nigeria. So I am not yet saying that it is our public health measures that led to where we are, but I do think we deserve a little bit of credit for the hard work done across the country. In Lagos, the incredible leadership of the Commissioner of Health and his team, in FCT and in the other states that were affected the most. But we know that it is not yet time to even talk about this. So we remain quiet, we work very hard. Saturday, Sunday, people are working for 10 months quietly to make sure Nigeria continues to be safe, because we know that we really cannot afford a large outbreak in Nigeria. I think you're on mute.
Okay, can you hear me? Yeah. Thank you very much for that explanation. And I'm happy that you used the opportunity to at least blow our trumpet. I mean, if nobody does it, we should do it. I was just trying to reconcile, our achievements, with the fact that our health system is still known to be very weak. And I'm looking at it, the challenge of the COVID beyond that perspective. Obviously, we need to improve upon the strength of our health system so that our capacity to deal with other health problems and all that will be enhanced. And maybe if we do that, again, the effects will even go beyond other ailments and prepare us much better for, some of these infectious diseases that, from what we've seen in the past, will almost inevitably pop up. We still have our Lassa fever and all that. Now, given the fact that we have less than 5% of our budget, much against the 50% prescribed by the World Health Organization, I'm sure those, in the authority, including, will begin to look at how we can increase the basket of funds available to health. One, ensure that even the 5% of fund is released, and if it's released on time. You can see the various dimensions. And then secondly, how, again, do you think we can get the private sector, again, to come in and avail us more funds so that at the end of the day, we have more money, to, again, begin to help us build the various health structures, that are, presently very weak. I look at the multidimensional, advantages that it will confer on us if we continue to work. And that, of course, will mean the issue of universal health coverage. I don't know whether you are liaising, with your, I'm talking of intersectoral, liaison with your fellow colleagues so that we can generally up the ante in strengthening our health system so that together, we can be stronger. Your take, please.
Yeah, thank you. And thank you really for making that point and broadening out the discussion. We have an opportunity now that might be a once in a generational opportunity, that health is really on everyone's mind. And the inadequacies in our present construction of the health system to deliver. And just like we have gone through radical transform in a few sectors in Nigeria, whether it's telecom or power, even though power hasn't really fully resulted in given the results that we expected. Throwing more money at the health system in its present construction will not yield the results that we need. So we really need for the health sector, and there's some energy around this growing now, a radical transformation in how we plan to deliver on health. We have many opportunities, many human resources. The private sector is growing rapidly, but we need the policy environment in the sector to drive change. That will not happen unless it's on the agenda of people, unless people also help us by pushing so that government realizes now is the time to do it. Because if you throw more money at it, it will go into bigger salaries because of the way our sector is constructed, lead to more strikes, and it will really not produce the effects that we need. So there's a little bit of momentum around this now to transform the sector substantially in terms of how it is constructed in order to deliver and whose responsibility it is. There are certain things that have to remain in the public sector, like the kind of work we do at NCDC. It's a global public good, outbreak preparedness and response. It will always be a social responsibility by government. But in terms of how you deliver health care services and the role of our teaching hospitals, our tertiary hospitals, how are they constructed, who should work there, and all of that needs a radical transformation for it to deliver effectively. I know, my final point, I know that conversations going on right now in government, but there also needs to be popular understanding and popular demand for the change that needs to happen for it to grow and meet our aspirations.
So, Dr. Dule, thank you for a wonderful presentation. I have some questions for you. Very quickly, I'm trying to look at an emerging paradox. America has arguably one of the most robust, health systems in place, and yet, the figures haven't been too good. Is it a fallout of the fact that you have about the most liberal democracy in the world? So that's number one. Number two, on the Q&A question, one of our participants wants to know how some of, the vaccines, some of the products, that you're working on can become, more available and more affordable and accessible, especially, to the low and middle income economies.
Right.
I think it's important. Your thoughts, please.
All right. So I'll save the question of access to products for a second. Some of the interesting sociologic constructs in the United States made us vulnerable. The most important is that we aggregate elderly into concentrated buildings. Your culture may not have that. You may have more of a nuclear family concept, multi-generational, 3 and 4 generation families that aggregate. So that has an epidemiologic benefit to your culture. Our culture says, no, let's take all of the elderly age 70 and up, let's put them all together in one building, and we have care centers and retirement centers and villages that are built around that. If you study what happened early on and the damage that happened in New York City in particular, it was a very flawed public policy. And the policy was, let's send people who've been positive for COVID in the hospital setting, inpatients, send them back out to the care centers, to the elderly care centers. So what happened was it was an ill-advised policy. It was very unwise. And what it did was it propagated many, it multiplied in deaths very rapidly. So I think concentration of the elderly is one of the key factors. The second is, we are a democracy. Americans pride themselves on their spirit of independence and pioneering spirit. And I want to add an interesting comment. When I landed in Nigeria, in Lagos, for the very first time, I got off the airplane after 30 hours of traveling and flying, and I literally got down on my knees on the floor at the baggage claim in the Lagos airport, and I said, this country is just like America. In my spirit resonated. There's a pioneering spirit about Nigeria. There's a get it done, make it happen, robustness. And it's not, you wouldn't find this, and I'm not disparaging of Kenya and other countries, but you wouldn't find this as this American-like pioneering spirit as strongly there. So Americans are fiercely independent. The other thing we have is we've had a very polarized political scenario play out in America, where you have two political camps, and I'm just being candid, all right? The Democratic side, which appears to be winning the current election cycle, decided to very quickly embrace a all hands on deck, science wins the day argument. The Republican side chose a pro-Donald Trump, what comes out of Donald Trump's mouth is the truth, I will trust that. Now, I'm just summarizing, these are overarching statements, but what happened was we had a divide amongst the population. That is not the case in Asian countries, and perhaps isn't the case in Nigeria, where there seems to be a respect for authority. We have no respect for authority in America. It's been lost. We have no respect for physicians, no respect for scientists, no respect for politicians, and I'm telling you, it's a blight on American culture right now. So there was a lot of political strife over public policy about COVID. So if you look at these two issues, elder care and public policy, I think it explains a fair amount of why we're seeing this. So America's had 3 humps of activity, right? We've seen in terms of incidence rates. And each of those incidence rates appears to track with a more free flow into culture. So We had restrictions. People griped and complained. They opened it up, and people started having holidays and big gatherings and parties. And then they tightened it again, and then they opened it up again. So we're seeing 3 waves in America, and each wave is building upon the other. My hope and my prayer is we've had enough of it. It's time for it to stop. So that's the first question. Second question is, how does one go about making healthcare products accessible? I gave you one very good example. The cetirizine plus famotidine treatment that is published, I don't get paid for that. I put my own money and my own time into that as a researcher. The physicians who did it, we weren't paid by anybody to do this. We weren't sponsored by a drug company to do this. We're giving away free information there. So one of the things that we need to understand is, what is the motivation behind somebody developing a product or a technology? And in most cases, the vaccines or things like remdesivir, it's a profit motive. Those businesses exist to make money. They exist for shareholder interest. But there are instances where some physicians, some practice groups, some scientists are just in it to be altruistic. That we just want to help. And so my motivation in working on COVID this last year, I spent 5 months of my life just helping, spending. I wasn't paid by anybody. That was on my own time. I did that. We call that on your own time, on your own dime. So that's one. I do think we're going to see a lot of progress in the vaccine field. You're seeing a lot happening there. The one caution I would give you, and this is my perception as a scientist reading the early reports, I believe the side effect profile of these vaccines for COVID are going to be very high. So individuals who experience are going to have flu-like symptoms, injection site pain, and at exceptionally high level. I don't know why that's true, but that appears to be the case. In terms of medications that can help, currently the emphasis has been on very expensive medications such as remdesivir. The hydroxychloroquine turned out to be a very, very lousy story. Had a lot of credit early on. It is definitely a very lousy medicine for use in a hospital setting. There's some debate about whether it's useful in treating, outpatients. There's debate about that, and there are opinions about whether it has any merit there. The other thing to be aware of are steroid treatments, glucocorticoids. There appears to be some benefit of steroid treatments in inpatients. And so, but we're beginning to slowly accrue information on how to treat inpatients, as well as vaccines coming on the near-term horizon. I don't know if that addresses particularly your questioner, but I'm trying to help. I believe you're muted. There we go. Very good.
So thank you it does, but you should understand my anxiety. The whole world is waiting for America to get it right so that the economy bounces back, and it's going to positively rub off on our economy. Once America's economy is good, hopefully they should buy more of our oil, and they should have a multiplier effect. We're going to give Dr. Chikwe Kwazu some 2 minutes to conclude his presentation. We also want to encourage our participants, to send in more questions so that we can quickly read them. We have about 10 minutes in all to conclude our session. Dr. Chikwe Kwazu, please.
Thank you very much, and I apologize for that short break. I'll just 3 slides to the end, really to say that moving forward, one thing we have learned from this response is the need for a multi-sectoral response. And this is normally very difficult to work with others because we are trained to work in our own silos very often. But to really succeed in a response like this that really requires action, not just within the health sector, at the education sector, security, humanitarian, on many fronts. We had to work together. So I think it was really great that the president set up that presidential task force to lead on this, to drive given the authority that they have, we're given to manage our national response. So that was very important. Next is really using this opportunity to build a sustainable infrastructure for the future. We had 3 labs, 3 molecular diagnostic million. Even with the 70 we have now, it's still insufficient. So I am working very deliberately with the resources available now, not just for the COVID response, but to build an infrastructure that will support us into the future. It's not just about the labs, it's about training people to work safely. Working in labs is a very complex thing. You can't train people in a few weeks. So we had to do what we needed to do in a hurry, but we're also building a whole new cadre of people that can do this work and do this work for Nigeria way into the future. And the one exciting thing about this country is our young people, their willingness to learn, their willingness to innovate, and their willingness to drive progress. So really excited about the work that they're doing. And so to conclude, really, and this is my last slide, is, we've had an opportunity to learn from previous outbreaks to some extent. And that's really what gave us the workforce, the experience to work on this. But we cannot wait for another crisis and work from crisis to crisis. We need to work in peacetime as well. And to work in peacetime is often very difficult in a context like Nigeria, where there are very many competing demands for resources. The pandemic has created opportunity for new leadership to emerge across the health sector. Within our organization, there are so many people that have really stood up. Right now, we're working with NYSC to open camps across the country. There hasn't been any major incident. We've supported PPEs, infection prevention and control, risk communication. We're testing every single youth corper going into camp. Imagine that operation. This is driven by leaders. Leaders, their voices are not heard, their faces are not seen. But these are the leaders that we are developing that will drive the future of the work that we're going to do together. We need to continue collaborating. I hope that we can build on the PTF to maintain these relationships that we have built through the crisis. And my final word is really, health security, the outbreak response work gets a lot of attention when there's an outbreak. But the truth is, in order not to shut down the economy when there's a pandemic, in order to keep the airports open, to keep our economy moving, we need to invest in preparedness and not in response. And to invest in preparedness requires stable, substantial, and sufficient funding for health security. It's not a lot. It might look like a lot when you look at it in absolute terms. But if you look at it vis-a-vis what the economy of this country has lost in the last 6 months, it will be a no-brainer that we have to invest in preparedness. So our economy is not faced with the tragedy that it has faced this year, with the tragedy that the global economy has faced. And so this is not just a wish for our country, it's a wish for the world, that we really look at health security as one of the priorities for investments, and not as an altruistic investment down a bottomless pit, but an investment that is required to keep our economy strong, open, and generating income for support our continuous development. So thank you very much. This was going to be my last slide.
Thank you very much, Dr. Chike Hikwazu. I have another question here, and it's for you, sir. And the question is Nigeria heading for a second peak of, the COVID pandemic? And maybe before you answer that again, on a lighter note, were you able to unravel why 2 states in Nigeria did not record, any COVID, the states in Southeast and one in the Middle Belt.
Yeah, so I'll start with your second question, and I'll go to your first. I think we were left with one state. Every state, we had confirmed cases in every state, just that some refused to really acknowledge it. But, I think it's important, and this is a conversation around the world, in the US, in the UK, we need to depoliticize infectious diseases. They're not interested in our political affiliation, in our boundaries, whether we're red, blue, or APC or PDP. They also don't want to know whether we gather for religious purposes, cultural purposes, to demonstrate all the viruses are interested in how close we are to each other to jump from one person to another. So I think it's important to depoliticize and remove the conversation from politics completely and really understand. And that's really an imperative for our leaders. And I love one advert on one of our major channels about masks, that masks are not a political symbol, the public health measure. But going back to your other question, it's, a second wave, we have all these terms. A second wave is not inevitable in Nigeria, but it will depend on the work that we do collectively. It's very challenging, even for us. For everyone on this call, I'm sure it's the same. The restrictions that we have placed on our way of life, especially in Nigeria, we're a social people. We gather for religious purposes, for cultural purposes, for business. And even if there's no reason to, we gather because it's who we are. We're social. So to now limit our ability to come together has been such a painful experience, to have to walk around with masks, but we really implore everyone to give this a few more months, to stay with it, not to travel unless you really have to internationally and even locally. These are just a few restrictions we need to put in place in order to have the opportunity to get back to life. There's a little bit of hope in the horizon. One vaccine has been announced. It has its limitations, but at least it's better than nothing. There are a few more coming on to getting to that same point before the end of the year. We'll have a few options. There's still a lot of uncertainty around how long the protection will last and all sorts of things, but at least there's hope. So I really say, in terms of a second peak, please, let's continue doing what we can do as a community. We as a government will continue with the difficult restrictions on aviation and things like that, but we need to see this not as something of what NCDC can do, or what government can do, or what our leadership can do, but what we can do collectively, because it's really through collective action and through really thinking with one voice that we can achieve or sustain the gains that we have made so far. I think you're on mute, sir.
Yes, I've done that. So thank you very much, for your take. I, again brought up the political issue just to let Dr. Tom Dooley know that just as much as politics has its own role to play in America, it also does have its role to play here. And yet the virus doesn't know PDP and APC in Nigeria, neither does it know, the Democrats and, the Republicans in America, and yet it's ravaging, the whole terrain. So the political actors have to put their acts together so that at least we overcome this pandemic that is, really proving a very hot one to handle. So I want to particularly appreciate, the presenters. I just want us to comment quickly about the vaccine and the availability, to the developing countries. Of course, Pfizer made a landmark, announcement some few days ago about the vaccine. The fact that it's going to be about 90%, effective. But what struck me was the fact that, the first rollout, understandably, will go to the Americans. It's understandable. I'm aware of what Moderna is doing. what hope do we have, for, Nigeria and the low, and middle income countries? How soon is the WHO, the World Health Organization, going to step in to ensure that at least in developing countries, Nigeria inclusive, those who are vulnerable, will be beneficiaries of the first set of vaccine rollout that we're going to see? I just want both of you to quickly just make a comment on that, before we conclude this session. Thank you very much. Dr. Dule, please.
Tom, do you want to go first? I think you're on mute. Okay, I'll go first. He seems to be having some challenges with his sound. So, around vaccines, the announcement from Pfizer was really important for all of us. It was, the first announcement, and I think there'll be a few more to come. The first thing to say is, other than the press release, we don't know that much yet about the vaccine, so we'll have to wait for more details to come. We do know that the vaccine in question at the moment will require some very stringent storage requirements at -70, -80 degrees, which will really provide a big challenge for us. But, we are working on this. Sister agency, the National Primary Healthcare Development Agency, is leading on this area of work for the country. In terms of access, our major strategy in access is through a coalition led by the WHO, together with two organizations called CEPI and Gavi. Together, they have negotiated with a lot of the major vaccine producers to ensure that all our countries have sufficient vaccines to vaccinate 20% of our population. So this is a very important coalition. And actually, something that will come out of this outbreak is that in the future,
I'm being nudged that our time is up, so let's just quickly round up.
Okay, so just that single thought. It's very inefficient in the world for countries to be negotiating individually with several companies or with products of uncertain efficacy and validity. And so we really need a global consensus, global governance. So I would really wish out of this outbreak that we come together and find ourselves in the world again, to find a way of negotiating collectively and not individually with vaccine companies for vaccines, therapeutics, and diagnostics. So thank you very much for this opportunity. If this is my final one, it's been a real privilege. Tom, over. I think there's an audio problem, so we might have to conclude here.
So thank you very much. We want to take a quick poll, and that should come on screen now. So we're urging our participants to respond or to be part of the polls, so that at the end of the day, we do our collation. Yeah, thank you very much. I think it's on screen now. Okay, well.
So just say, so that's the end of the healthcare section. We will be moving to the next session, the next meeting, and then we'll close.
Okay, so that is the end of, the session on the health sector. We want to thank everybody for, having been part of the process. I'm sure we've all been informed, educated, and enriched in our knowledge. In the next 5 minutes, we're going to move to the next sector. I want to encourage those who can make out time to be part of it, because it's going to be as informative, it's going to be as enlightening, it's going to be as educative as the session that just ended. May God bless you all as you continue with us. Thank you very much.